Going on the schedule, the next speaker is Dr. Ricardo Araya. He's professor of psychiatry of Bristol University. Please, Dr. Araya.
This is for the slides, right?
Yes, so it goes forward and backward. And here you're going to.
Yeah.
Okay, I have water here for you.
This is the one I use.
Yes.
Lovely. Thank you. Bom dia. Well, first of all, the bad news. What I'm about to tell you has nothing to do with Paris Hilton. There is no glamour at all, unfortunately. After the presentation from Jose Alexandre, I've been thinking maybe that I need to change my research subject. We can talk later. I'm a psychiatric epidemiologist. I've been working on this for about 20-something years. On the sort of first phase of my life as a researcher, I was very interested in the epidemiological studies, measuring things, association studies and things like that. But then it came to a point when I realized that I wanted to do something that could make the difference, but could make the difference to people. And so I became interested in trying to see whether or not we could design good intervention programs, we could implement those things and test whether or not they work. It was at about the time when people became a bit obsessed with this idea of evidence-based medicine, that everything had to be based on evidence. Unfortunately, I think that quite a lot of what we do in medicine in general, I don't want to blame it only in psychiatry, is not based on any evidence at all. And it is rather unfortunate because, there are lots of resources, hopes, and various other things involved. Okay, so let me tell you a little story. I'm not a child psychiatrist. Most of my research in my first 15 or so years were among adults. And then I moved to work in Bristol, and in Bristol I was lucky to find that there was a huge, is it too close or too far? Slow? Closer. It's not Paris Hilton, right? Okay. Is it better now? Okay, good. I'm not a child psychiatrist, but I moved to work in Bristol where they have a wonderful cohort, and I heard from one of the speakers earlier about cohorts. And this is a birth cohort. The kids are now about 20 years old, 13,000 kids. So it was a wonderful opportunity to look at, use the epidemiology to look at, early origins of mental illness. So I became interested in children and adolescents, and I started to learn. For those of you who are very young, the good thing is that you can always learn more and more and more. Even for people like myself who are rather old, I found it fascinating, and I kept my brain alive. So I started to do lots of stuff with children and adolescents, and then I became interested in trying to test some of these ideas to see whether or not you could improve the mental health of children and adolescents. So that's how I became involved in this. What I'm about to tell you, this is new data. These are two very large randomized controlled trials for the prevention. I'm a little bit doubtful to use that word because people use it for different things. The real true, primary prevention is the one that prevents the onset of new cases. What I'm about to tell you here, it is the prevention that reduces the load of symptoms, which is not exactly the primary prevention that some people speak about. As you all know, depression and anxiety, emotional symptoms are very common among adolescents. I was rather surprised to see some of the numbers of the first speaker, actually. I thought it was quite low in comparison to other epidemiological studies among adolescents. So, but other than being very prevalent, also they're poorly identified, and there is very little on offer for teenagers, especially in Latin America. As we all know, if you happen to suffer, as some of the longitudinal studies show, if you happen to suffer from some of this disorder, your prognosis, your outcome in your future life is not so good. So there is a lot to talk about how you kind of sort of tackle some of these problems, but in general, the first line approach, it should be a psychological treatment. There is some reluctance to prescribe antidepressants, especially in Europe, for children and adolescents. So schools, as you can imagine, offer a great opportunity to have access to adolescents. And that's why we became interested on this thing. Now, in 2012, this is the most recent Cochrane review of psychological and educational interventions for the prevention of depression in children and adolescents. So this is fairly recent. There hasn't been anything after this. And this is led by Professor Merry from New Zealand. Essentially, this review, what it shows, that there were only 31 universal randomized control studies for the prevention of depression, and only 3 of these had more than 1,000 subjects. I will come back to that because there are issues about power that are really important to bear in mind. And most of these studies had very serious methodological problems, so whatever you could say, it will be affected by the quality of the studies. Interestingly, they came to the conclusion that there is some evidence that universal depression prevention programs may prevent the onset of depression. And what is the evidence that they show? Now, let me show you. The first thing is, these are results almost immediately after the intervention. And as you can see, the total, these are standardized mean differences. But as you can see, it's very, although it is significant, it's very, look at the confidence intervals, it's very close to 0. So this is a very weak effect to begin with. Quite a few studies, most of the studies I would say, do measure things immediately post-intervention. But then afterwards, many of these studies stop measuring things. As you can see, less studies now when it comes to 3.5 months depression mean scores. And what is happening is that all the effects are beginning to gradually fade away. So the longer you go, if there is an effect, it begins to disappear. And this is for 12 months, and by 12 months, it's gone. There is nothing. So this is the evidence of the latest and most important systematic review of prevention interventions for adolescents. Now, why did I want to show you this? I wanted to show you because, you know, science is you know, sometimes, you know, and I hope you will share this with me, you know, sometimes people use science to promote ideas. Okay, I'm not saying that you know, Sally Mary and her group have actually used science, but I think they've presented the results and conclusions in such a way that it can actually mislead people to believe that there is something where there is nothing. This is just to show you how these things happen. This is a commentary from a very well-known professor and a wonderful guy, Bill Beardsley from Harvard, essentially commenting on the Cochrane review, and he was saying, you know, the intervention reduced significant depressive episodes and symptoms, post-intervention and 3 and 9 follow-up. Although the findings are robust, the effects are relatively small. At least he is acknowledging that they're very small. But the message that has been presented is that these things work, okay? So these are the two trials. These are new trials, this one, and these are the two, by the way, the two largest trials for the reduction of emotional symptoms among adolescents, the two largest ever done so far. So the first one is in Chile, the second one is in the United Kingdom. So this is the first one. It's a school intervention to improve the mental health of low-income secondary school students in Santiago, Chile. And there's a large group in here. In fact, one of the members of our group, Dr. Vania Martinez, is sitting in the audience. So essentially what we did, this is a cluster randomized controlled trial. We randomized 22 schools, 11 in the active, 11 in the control groups. The schools were eligible if they were public, secondary high school, mixed sex, and had at least one, what we call primero medio, which is about 9th grade. Okay, you'll see more about the age of these kids. Now, the paper is now in press, so you can find it in JAMA Pediatrics. I don't think it is online yet, but it should be coming in a week or so. So what is it that we had? We had an intervention in a control group. The control group, basically, we didn't do much other than measuring. And in the intervention group, we had 13 sessions that they were supposed to be weekly, and I will come back to that, plus 2 booster sessions 3 months after completing the acute phase of the intervention. It was mostly based on cognitive behavioral therapy with some problem-solving skills also taught to the kids. It was delivered by 3 trained facilitators per class, and you may think, why 3? And I'll come back to that because it's to do with discipline in the classes, in the classroom. All the people were trained, received, regular supervision from very experienced practitioners. They both had detailed manuals. We spent 18 months preparing the randomized control trial. A group of people, 18 months, and I will show you some of the material. I mean, the actual intervention is beautiful. I have to say that the one we developed in Chile is much nicer than the one that we developed in the United Kingdom. I'll show you some of the stuff that we did. So, roughly, this is what it covered the first 11 sessions. The first one, it was general information, introducing the kid to the ideas, where we're going to be meeting weekly here, and that we're going to be doing lots of things together. Then we introduced the idea of the model, that thoughts and feelings and actions are all connected. We introduced the idea that you could identify some of these sort of automatic negative thoughts, and you could eventually do something to change those, and if you did, maybe you will feel better. Some basic stuff about regulating their own emotions, 3 sessions on problem solving, and then putting it all together and helping them prepare for the future and prevent relapses. So that was roughly what it was. A few pictures because, in essence, this is slightly different. This is about human beings. I know that human beings have cells and molecules and proteins and all those things, but this is how it happened. These are the people. These are the actors. This is one school, as you can see, mixed. What you see here, the kids are holding their manuals. I will show you an example of the manuals. But, this is a typical class, They're all, distracted, talking here. Look at this one, It's not easy. It's not easy to deliver intervention in the classroom. It's not easy. All the sessions had a PowerPoint, following the whole things, and then the kids were in there. In fact, one of the things that I do realize that, these are all kids coming from very poor background. And when we came in there, with an intervention that had a PowerPoint presentation, and they were absolutely, they'd never seen this thing in their life, It was just kind of sort of weird for them. All the session had a little card that they kept on top of the manual. They were all, the graphic design. This was a summary of what they were taught, the main things of each one of the sessions. So there was a lot of material for this kid to work with. You see here they are working with their manuals, alone. Certain things they will work in small groups, certain things they will work in larger groups. Here it is, you see? You see, this is what I'm telling you. This is why you need 3 facilitators, you know, but that will destroy the cost effectiveness of the trial. They had lots of staff that will work in groups with examples and exercise and trying to use what we're teaching them, you know, cartoons, examples, and so on and so forth. Here they're working with one of them, as you can see, in groups, small groups. And you know, some of them, as you can see, you know, one interesting thing about teenagers, they tend to work, you know, there is a kind of sort of by the same sex. You know, boys with boys and girls with girls. But, you know, we've all been teenagers and we know why. But that's the way it is. And then they will present some of these exercises to the group. So here are these, you know, kids actually. This is one of the facilitators. They're presenting that we will have posters that we will leave in the classroom after each one of the sessions. They wouldn't last more than 2 days, as you can imagine. You know, they will rip it and, you know, do whatever they, you know, throw it around. But that's the way it is. You know, these are, you know, real classroom in the real world. So anyway, did I skip? No. So we did the intervention, the 11 sessions and this and that, and then we measure the outcomes. And the primary outcome was the BDI, the back depression inventory, at 6 months. But we also measured it at 18 months after completing the intervention. And we have 3 other secondary outcomes: anxiety, a measure of personal failure, and problem solving. This is roughly the numbers that we had. 11 schools in each one of them, more than 1,000 in the control arm, more than 1,220 in the intervention arm, and we were able to achieve close to 80% follow-up data. Now, these are big numbers, believe me. These are big numbers. You know, 2,500 kids, and to follow them over time, like sort of 2.5 years, it's big numbers. Now, randomization worked out, you know, wonderful. As you can see, you know, they were pretty well balanced, the 2 groups. Mean age is around 14.5 years old. Quite ill, you know, lots of depressive symptoms. Most of them had never seen anyone for help. Lots of suicidal ideas. So just what I want to show you in here is that these are not, you know, the first surprise for us, it was to see that they were so ill. We never expected that they would be so ill. And then when we tried to publish the paper, you know, reviewers, you know, they raise the issue and they say, you know, how can they be so ill? But, you know, that's what it is. So here are the bad news. 4 years, 4.5 years took us to do this trial. Loads of people involved working on this, and essentially the results are negative. It doesn't work. What you can see in here, this is the control group at baseline. Both baseline and intervention, pretty similar scores. But the change, although there was a little drop, is virtually the same. So no difference between the groups. It did not work to reduce depressive symptoms according to the Beck BDI-2. And there was no evidence of any effects at 18 months either. When you look at secondary outcomes, exactly the same picture, with the only exception, it is for anxiety at 6 months, there was a small reduction. But if you think of it, you know, this is like sort of less than 1 point on a scale of 15 points. You know, it's less than 10%. I mean, you know, it's meaningless. So, bad news. It doesn't work. It didn't work. It's you know, it was sad for us. Now, why didn't it work? Well, this is, you know, because a lot of people, you know, targeted interventions seem to work better with kids. You know, when you look at, you only intervene the kids that they do have very, you know, symptoms. They tend to work better. When we analyze the data only for those that had loads of symptoms at the beginning, essentially the same story. Nothing changed. So it did not work. So this is the first large randomized controlled trial of a school-based intervention for emotional symptoms from a non-Western country. In fact, there is another one from Mauritius. with only 400 kids. We did everything we could to develop a good intervention. It was based in all the programs that had worked in other countries. We consulted almost every people who had tried these things, to try to get it right. It just did not work. Why did it not work? Well, number of reasons. Maybe, it's very difficult to modify the functional symptom or change behaviors in large groups and with limited time. Maybe the facilitators didn't have enough experience or training. Lots of things happen in schools, You have to be prepared when you do real world effectiveness trial that nothing is going to work exactly as you planned it. In the middle of one of these things, we had a student strike. So all school were, stopped for like 3 weeks. So things happen, so you have to be prepared for that. And I think this is really important. Populations with marked social deprivation are very difficult to change with targeted and time-limited interventions. And I think, this is really important because at the moment there is a push, a very strong push, which is coming from economists. There's a guy called, some of you may have heard of this guy, Heckman, who was a Nobel Prize in the 80s, an economist, who believes that early life intervention to modify what he calls non-cognitive skills are the best possible social investment that can ever be done. So that enthused the World Bank and various others. So there is a lot of money going around to do those things. And essentially, they're doing things which are even lighter than what we do here. 6 sessions and things like that, and expecting that there will be huge changes in terms of the outcome of these kids when they become, grown-ups. It's a gamble, but it may not pay off in the end. Floor effect, we don't think it is a floor effect. As I said before, this kid had loads of symptoms. So it is floor effect, but for those of you who don't know, it's basically that if you give an intervention to people who have no symptoms, you can't change nothing, okay? So if most of these kids didn't have any symptoms, you couldn't change anything. But essentially that was not true because they had loads of symptoms. Now this is the one in England, published in BMJ late last year. Similar kind of thing. The main difference that we were only interested in high-risk students. So we selected those kids for the primary analysis. We selected those kids that had a higher level of symptoms only. Okay. So is classroom-based CBT effective in reducing symptoms of depression among high-risk adolescents from age 12 to 16? Another big cluster randomized controlled trial, a shorter intervention, only 9 sessions. Again, led and trained by supervised health facilitator. And in this case, we had 3 groups. Because there's been a lot of talk about, whether or not you should have a placebo control, where you go and try to do something with the kids, the same number of sessions, but it's not really therapeutic. So in this trial, we had that. And we measured the main one. So these are the 3 groups. The usual control, which is basically the teacher and the usual curriculum in England. The attention control is the placebo one. There was a teacher plus 2 assistants, and that they deliver some more intensive sort of talking to the kids. Okay. And this is the intervention, which is a RAP developed in Australia, the Resource Adolescent Program that had been proven to be useful. I'm not going to have time to tell you much more about these things, but these are the ingredients of the RAP. And in essence, it's a sort of CBT base, mostly, with a little bit of problem solving and various other things. It's not essentially very different from what you see, the thing here is that you don't reinvent the wheel. Most of these programs are very similar today. So that was a study roughly. There were like sort of 5,000 kids eligible. Most of them accepted to come in, like 90%. The baseline, 95% came to the baseline. And then what you don't have in here is the ones that are high risk. The high risk, it was only 21% of the total, so about 1,000, out of which we were able to reach 80% at 12 months. And here are the results. Again, bad news. It doesn't work. Here it's baseline, here it's 12 months. If you look at the across groups, essentially the same changes. If anything, the usual control, simply the weekly meeting that all schools have in England, may have done a little bit better than the two more active ones. So, really bad news. If you look at secondary outcome, exactly the same picture, nothing really changed. Very good study. Most of the kids attended at least 80%, 60% of the sessions. Good fidelity, so it was delivered as it was expected. Excellent supervision, good recruitment, wonderful sample size. When we met, these were some of the reasons that why we thought that, the problems in England were roughly things to do with behavior. You're not a teacher, you can't do anything to me. Teachers have different views about what mental health is. Not only different views, but also have little time to do anything else. They're overloaded. There is an issue about time. There's never enough time. There is an issue about relevance. I'm not depressed, so why do I need to do these things? A lot of kids were asking for that. Schools are assessed on academic attainment, so this thing wasn't really, into the focus of the thing. And planning is very complex when in schools, they have lots of competing priorities. You go in there and you say, I need an hour a week. Most of the headmasters, will tell you, you can't have that, We don't have the time for that. So in summary, these are the two largest trials ever reported, school trials for emotional symptoms. Both are unequivocally negative. If we add these findings, and I think this is something really important, if we add these findings to the previous trials included in the Cochrane review, it becomes completely negative. So all that evidence that it was presented in there, trying to present it as if these programs work, unfortunately, it doesn't hold. It doesn't hold. So there is no evidence to support the effectiveness of universal depression interventions in a school. And I'm going to finish with some quick. So what do we do then? So how many school interventions are currently being implemented without any evaluation that show effectiveness? I mean, I'm pretty sure that here in Brazil, you must have dozens of these things done in a school. In Chile, there are something like dozens of those, and no single evaluation. Should we stop doing these things? Maybe not. Maybe, but at least we should pause and think very carefully, why is it that they're not working? And what do we need to do in order to make some of these things work? Because some of them seem to work. I mean, at least the targeted intervention and individual therapy seem to work. So maybe there is something, but we still don't know what it is. Just before I came, in one of the newspapers in England, there was this thing. Teachers need to drive the research agenda. If teachers want politicians to base policy on evidence, they need to accept that randomized trials are the way to show what works. So this thing came in The Guardian, there was a big thing, it was in the morning news and so on and so forth. Yes, I know this guy is from IOP, I know, Ben. Yeah, it's a psychiatrist, by the way, this guy, but he's now become a celebrity. So maybe he's got a better chance than myself to be approached by Paris Hilton. Anyway, I wish him luck, actually. So to conclude, and what I wanted to tell you is that we talk a lot about evidence-based things, but the reality is that we don't even invest on trying to get the evidence. If you really want to get the evidence, you really need to have good randomized controlled trials. There is no way out. That is the most powerful design to test if an intervention works. Like it or not, that's the reality. If we not do this, we may continue to waste resources. And there is a lot of that. Unfortunately, schools and many other health problems are often of unproven effectiveness, especially in Latin America. And this is bad news for Brazil and Sao Paulo. FAPESP, we heard them, does not fund clinical trials. It doesn't. And I want to provoke you because, it's really unfortunate that an agency with so much money, I'm saying this thing responsibly, and I can, if you allow me, I can even show you the email that I had in which it says that they do not fund clinical trials. So, you Paulistas, you have a task. You have to talk to these guys, and you have to convince them that if they do not fund these things, they're not going to know what works. So it's entirely in your hands. And I wanted to provoke you with this. And for those of you who may wonder if I'm telling you the truth about this, I'm more than happy to show you the evidence. What I'm saying is evidence-based. So I think there is a task here for the locals to convince that if you don't do it, you'll never know. And I think that was the end of my presentation. Thank you for your time.
Thank you, Dr. Araya, for your great presentation. And we have time for 1 or 2 questions.
Thanks, Ricardo, for your wonderful work and unfortunately negative. I was wondering, if you look at the data, I mean the back inventory for depression, did you look at like categorical using cutoffs? If you look at change in the total score, would that make any difference?
None at all. I can show you the table. None at all.
Thank you.
By the way, cutoff points, it's a really interesting thing. One thing we discovered, and once again, for those of you who are doing research in this field, is that boys and girls have very different cutoff points.
So no difference at all.
Thanks very much. Thank you, Ricardo. Helen Herman from Melbourne for that very fine presentation. I'm interested in your comments on information about whole school interventions or more complex interventions in schools and interventions that have the target of changing mental health status as distinct from symptomatic status. I'm thinking about meta-analyses done by people like Stewart and collections of data from DataPrep in Europe that seem to be telling us a different story. It's not contradicting what you're saying, but suggesting that interventions in schools that change relationships, that alter the whole school environment, may be some of the most promising things in terms of improving mental health as distinct from changing symptom status.
Well, when you do a randomized control trial, the first thing you have to do is that you have to set out what is it that you're testing and what is the outcome that you will be using to evaluate if you have changed that. In this case, we decided for symptoms. If you want to do an intervention to change the quality of the environment or this or that, it's fine. I mean, you can do it. I mean, to me, it's quite challenging actually to come up with good measures for some of the things that you've described, Helen. Yeah, but it may be that if you go in these schools and you measure other things, maybe it did have an impact in some other way. But that's not, the thing about randomized control trial is that, you have to declare your intention at the start. And that's why you have to have a protocol, you have to register your child. This is what we decided to do. And it turned out that it was negative. You know, maybe you're right, Helen. Maybe if we had chosen another indicator, we could have been lucky. I don't know.
Congratulations. This is immense amount of work and very important data that comes out of it, even if it's negative. I was just wondering how the recruitment worked, and in the classes, there were only people with high levels of BDI?
No. The intervention is universal for everybody.
So you just randomize the classrooms. The randomization was based on classroom, schools, or?
In the UK, it was randomized by classes. In Chile, it was randomized by school.
Okay.
But everybody received the thing. You know, this is another thing. You know, that some people say, when you go to school and a lot of the kids, you know, don't have any symptoms, they get bored, and they start showing you the fingers as they did there. You know. Yeah, I mean, it happens. So this is probably, you know, one reason why targeted intervention to those who do have symptoms tend to get better results. But it's also because when you get symptoms, you have more room to change. Okay.
Yeah.
So
sure.
there are a number of reasons why targeted intervention may work out better.
Yeah, I was just comment. I think everybody is interested in discuss that, because I think there are two different concepts. We use BDI for people with disorders, and we classify them, and then we check if it works. And now you're talking about the general population, and symptoms in the general population do not quite characterize what we call depression. So are we talking about levels of happiness or lower depressive symptoms and so on? So perhaps the two concepts mixed might have an effect on this kind of interventions. It's just a little comment.
Yeah, thanks, Rodrigo. That's interesting actually, because we did. This is a very controversial thing, by the way, because there are some people who believe that in this sort of dimensional thing that we have from total and complete happiness, almost manic, to total and complete depression. And so there are some scales that they try to capture the positive side of health, of mental health. Okay, in the case of BDI, is the absence. Some people believe that symptoms is a reciprocal of not having symptoms. So if I ask you, have you been depressed over the last 7 days, and you tell me no, okay, so I cannot say how happy you are, but at least you're not depressed. Now, in this study, we also developed something that we call, I think we call the emotional thermometer. It did try to capture that, and then we also analyzed that data, and nothing. So it wasn't really that we weren't capturing the positive side of the story. BDI, it's a measure that we tried several before we did the study, by the way, and then BDI proved to be as good as any of the other. BDI, Reynolds, CSI, lots of them. Given that our intervention was trying to change some of the cognitions and this and that, in the end we settled with BDI. And also because a lot of the previous studies had used the BDI, so allow us to compare with the others.
One more question.
Brian Rush from Canada. Thank you for a good presentation. I'm just wondering if you could comment, given A, the negative findings for the prevention program, but B, the relatively high level of problems, disorders, symptoms. What's your perspective on introducing more universal or targeted screening, then with referral perhaps to outside agencies? Because that also comes with some controversy about whether the majority of those kids would in fact grow out of those problems, and there's some research that suggests that many of them will, of course. So just some comments on that might be helpful.
Yeah, that's a very good point, Brian. Thanks for that question. It's a very important point because the fact that this intervention hasn't worked, it doesn't necessarily mean that nothing works. And initially, when we were planning this study, our initial approach to it, we wanted to develop what we call a step care program. And essentially what we wanted, it was to go in the school, screen the kids, and then those who had symptoms, high level of symptoms, give them something for a period of time, see if they improve. If they didn't improve, step them up to a more sophisticated and intensive treatment. That was the initial intention. We went to school, and most of the schools said, no way, no way. Well, first of all, you come in here, and we don't want any of the kids to know if there are cases or no cases, because they will be bullied by the other kids or by whoever. So if you want to do something in the school, you give it to everybody. We don't want anyone to be told, because the kids, you know how they are. They're going to be pointing the finger, look, Maria is leaving the room now because she's going to the treatment for the loonies, that kind of thing. So it was not possible. Now, we are trying, and Dr. Martinez is working on something, which is trying to find some way of identifying kids with problems in schools, and then trying to refer them to a primary care clinic nearby, and then see if they can be treated. We will see. That will be a sort of individual, one-to-one basis treatment. We don't know. I mean, the only thing that is clear, and it comes from what you said, Brian, that the level of symptoms that we found in here, it was unbelievably high, incredibly high. I think something like 20-something% of the kids qualified for clinical depression. If you think of it, one of every 5 kids is clinically depressed. What future do they have?
So thanks again, Dr. Araya.